Hi. Thank you very much for your most welcoming invitation to the International Conference on Sexual Health and Fertility Treatments. It's a very big pleasure and honor for me to be there with you, at least virtually. In the next 15 minutes, I will be summarizing patch and app systems for premature ejaculation, and basically I will be talking about a product that we have developed. Here are my disclosures. I'm basically involved with the company who is developing the patch. During ejaculation, there are some stimulations occurring on the glans penis, and those stimuli are taken by sensory afference to the pudendal nerve, and then they are taken to the L3, L4 spinal ejaculatory generator, and then it is passed to the medial preoptic area, paraventricular nucleus, and nucleus paragigantocellularis. After the approval coming from the central nervous system, the stimuli comes back to the spinal ejaculatory generator, which acts as the maestro of ejaculation. From one side, it's stimulating the secretory center, which is responsible for emission. And from the other side, it is stimulating the mechanical center, which is responsible for expulsion, where the contraction of bulbospongiosus, bulbocavernosus, and perineal muscles occur. This video beautifully demonstrates what I have been mentioning about when the sexual stimuli is taken to the central nervous system, and once the stimuli comes back to the L3, L4, the emission phase starts, and during this stage we can observe the contraction of epididymis, vas deferens, and seminal vesicles, and finally the prostate. Then the ejaculate occurs right in front of the external urethral sphincter, which triggers the second phase of ejaculation, which is expulsion. And during the expulsion stage, the bulbospongiosus muscle, this muscle contracts 8 to 11 times in order to increase the intraurethral pressure. Then we observe a contraction in the bladder neck. With the release of the external urinary sphincter, ejaculation occurs. Then the subjective feeling of orgasm comes. Whenever this ejaculatory reflex is sooner than expected, we are talking about men with premature ejaculation. In those men, we see a more steep excitement phase, which is followed by a shorter plateau phase, and very rapid ejaculation associated with orgasm. Is premature ejaculation a serious problem? Yes, it is. It affects 3 to 30% of the male population. Therefore, it is cited as the most common form of male sexual dysfunction. And today we know that it causes important psychological problems such as diminished self-esteem, anxiety, embarrassment, and relationship problems. Currently available treatments for premature ejaculation are topical anesthetics, which inhibit penile sensory receptors, and SSRIs, which increase the serotonergic inhibition in the central nervous system. However, in the recent years, there are many other treatment options for premature ejaculations, such as tramadol, clomipramine, DA8031, which is a recently developed Korean SSRI, modafinil, GlaxoSmithKline, molecule, PD5 inhibitors, oxytocin receptor blockers, such as cligosiban, epersiban. Alpha blockers are being used. Instead of topical anesthetics, some authors suggest injection of hyaluronic acid into the glans penis to create a barrier for glans penis numbness, and dorsal nerve resection or cryoablation are also recommended by some Russian and Asian researchers. In order to block the expulsion phase of ejaculation by paralyzing the bulbospongiosus, bulbocavernosus, and other perineal muscles, botulinum toxin inhibition is suggested by our group, and then transcutaneous electrical stimulation is also suggested. Of note, some authors are also testing the transcutaneous posterior tibial nerve stimulation, which is used for neurogenic incontinence, for the treatment of premature ejaculation. I will be focusing on these two treatment modalities. The idea has been published in 2009. We hypothesized that if we inject botulinum toxin to bulbospongiosus muscle, those muscles will not be able to contract 8 to 11 times, which is necessary for ejaculation, and the ejaculation delay may occur. We have tested our study in the United States, and we have injected Botox to the bulbospongiosus muscle of rats. Those muscles are very evident during dissections, and we have injected botulinum toxin to those muscles, and we have demonstrated that low dose and high dose botulinum toxin injection were associated with a significant increase in ejaculation latency. These videos are from our study. Here you can see a rat with saline injection, and here you see the rat with Botox injection to the bulbospongiosus muscle. Here you can see that this rat has ejaculated. Now the rat is cleaning his face and resting and relaxing, whereas the rat which has been injected with Botox is still continuing his activities, sexual activities, and the ejaculation latency almost doubled. And now the rat has ejaculated. Our study has been confirmed by another group in Turkey, but in this group, instead of doing live assessments, the authors injected parachloroamphetamine, and they have measured the contractions in the bulbospongiosus muscles with electromyography, and they have demonstrated also a dose-dependent increase in parachloroamphetamine induced ejaculation latencies. Considering the promising findings of those studies, the company which produces botulinum toxin conducted its clinical trial, but they have never published their results in the form of a scientific article, but by the regulation, they had to put their results to clinicaltrials.gov website. And here you can see that the baseline ejaculation latencies were similar. However, after some doses of botulinum toxin injections, some patients observed significant increase in ejaculation latency, and this effect was obvious, especially in this dose. We don't know which dose it is. It was evident till 3 months. Another study from China, which is published in a Chinese article in 2018, demonstrated that botulinum toxin injection can be effective in half of the patients who are suffering from lifelong premature ejaculation. Our results not only triggered some scientific research, but also it was popular in the tabloids, and an Israeli company, an Israeli researcher found out that he can also paralyze those muscles, those bulbospongiosus and ischiocavernosus muscles, with electrical stimulation. Actually, as urologists, we know we are not that unfamiliar with those electrical devices. Intermittent electrical stimuli is commonly applied to superficial muscles, especially in the physical therapy field. And also we are using those devices for pelvic floor muscle training among patients with lower urinary tract syndrome, stress urinary incontinence, and erectile dysfunction. So the technology has been developed in 2014, and the patent has been approved. FDA clearance has been obtained in 2021, and 2 articles published. What is the advantages of such a technology compared to topical anesthetics and SSRIs? Well, the effect can be observed immediately. I mean, whenever you stick the patch and when you push to the start button, the electricity is there. So the effect is localized. and the effect is specific to the intercourse, and the side effect is slight disturbance. However, desensitizers can be associated with numbness of penis, and it can be transferred to the female partner, which can be associated with female anorgasmia. And as we all know, SSRIs are not innocent drugs. They can have systemic side effects, and it is associated with nausea, erectile dysfunction, reduced libido, headaches, drowsiness, and even now we are recognizing a phenomenon called post-SSRI syndrome. So the SSRIs can deteriorate sexual functions, and we have to be very careful whenever we are suggesting those medications to our patients who are suffering from premature ejaculation. The proof of concept study was conducted with regular transcutaneous functional electrical stimulation devices. So we have applied 10 devices to the perineum of the patients, and we asked them to masturbate, and we have demonstrated that masturbatory ejaculatory latency time is increasing 3.5 folds when we apply electrical stimulation there. Our study has also been recently confirmed by another Turkish group, and those authors also used a commercial TENS device, and they have applied electricity to the bulbospongiosus muscles, and they have administered parachloroamphetamine to induce ejaculation, and they have demonstrated that low frequency electricity and high frequency electricity are much better ejaculation latency providing electrical tools, especially low frequency electricity was associated with the most significant ejaculation latency delay. And our clinical study also recently published in the Journal of Sexual Medicine. We have recruited 70 men with the complaint of premature ejaculation, and one group received sham device, the other group has received active device, and as you can see, we managed to increase ejaculation 2 to 3 folds, and the majority of the patients were happy with this device. In conclusion, physiology of ejaculation is complex and incompletely understood. Current medical treatments offer several effective options, such as topical anesthetics, SSRIs, clomipramine, PDE5 inhibitors, and tramadol. There are many more in development and trial. TENS device, which is developed by a Viridity company, can be an optimal treatment for premature ejaculation because it is on demand. It is drug-free, and it's safe and effective. However, continued research will identify mechanisms for new therapeutic targets for premature ejaculation. Thank you so much for your attention, and if you have any questions, I would be more than happy to answer them during the live session. Goodbye.